All right, good morning, everybody, and thank you for joining us here today. I'm Cheryl George, and I will be your host for today's session, and we are here to discuss pharmacy trends and the impact to your healthcare dollars. Here at Blue Cross North Carolina, it is not lost on us the escalating costs of healthcare. We know that prescription drug costs are rising at nearly twice the rate of overall healthcare costs, and we also know that these challenges aren't siloed. They go hand in hand, which is why our medical and pharmacy teams work together to reduce total cost of care. Today, we would like to demonstrate just a few ways that we use data insights, cost-saving programs, and strategic care coordination to address these concerns, ultimately managing costs to you, the employer, while also informing precision care management down to your employees. In just a moment, I will introduce our speakers for today, but before that, I'd like to review just a couple of housekeeping items to note. First and foremost, this webinar is being recorded and will be provided to all of the registrants after the session. If you have a question during the webinar, please use the Q&A feature instead of the chat. We have some experts behind the scenes to help answer any questions, and we do have some time set aside at the end as well. Throughout the webinar, we will discuss many solutions aimed at controlling costs and improving quality. Just a reminder that availability for these solutions will vary. So if you have a specific question, you can use the Q&A feature for that, or reach out to your authorized Blue Cross North Carolina representative for some more details. Lastly, at the end of today's session, a survey will pop up in your browser. Your feedback on these surveys is invaluable, especially as we move into planning for the 2025 series that we're looking forward to. As an extra incentive, by completing the survey, you will be automatically entered into a drawing for a $25 Amazon gift card. So please be sure to keep a lookout for that. Joining me today, I have 4 expert presenters. We have Meaghan Woodhouse, Manager of Healthcare Solutions. Meaghan serves as a subject matter expert regarding opportunities to improve health and impact affordability. She currently leads the development and implementation of our enterprise-wide diabetes strategy. Joseph Albright, Associate Vice President of Corporate Pharmacy. Dr. Albright directs the commercial pharmacy programs for Blue Cross North Carolina, which serves over 1 million members. These services include traditional programs such as network formulary and utilization management. During his tenure at Blue Cross, Dr. Albright focused on modernizing the clinical policies for prescription opioid use and for medication-assisted therapy, promoting diabetes management, and partnering with providers to increase quality and decrease cost. Brenden O'Hara, Manager, Pharmacy Professional Engagement and Quality. Brenden began his career in community pharmacy, working in various positions from staff pharmacist to district pharmacy manager. He began at Blue Cross North Carolina in 2015 and currently manages a team working on value-based care programs, implementing pharmacy programs in health systems, provider groups, and most recently, community pharmacies. And last but not least, we have Rhonita Mitchell, Director of Specialty Pharmacy. Dr. Mitchell's pharmacy experience includes retail, clinical, specialty, and managed care pharmacy. In addition to her registered pharmacist license, she is also a certified specialty pharmacist. Since joining the Blue Cross North Carolina team in April of 2022, she served as the Director of Pharmacy Shared Services, leading the pharmacy vendor management and compliance teams prior to transitioning to specialty and innovation team. Meaghan, Joey, Brenden, and Rhonita, thank you so much for joining us here today. Taking a look at today's agenda, we are going to start by discussing the current pharmacy landscape, healthcare costs, and the challenges that we see. Then we will outline the difference between medical benefits and pharmacy benefits and just how exactly they differ. We will discuss the many facets of care coordination and what we like to call the power of one. We'll demonstrate the value of medical and pharmacy integration with some exciting proven results to showcase. And of course, we cannot forget specialty drugs and GLP-1s, the 2 hot topics on everybody's mind. And then, of course, we'll leave some time at the end for those burning questions. With that, I'm going to turn it over to our panelists. Meaghan, we'll start with you. I'm wondering if you can tell us about what you're seeing trending in healthcare costs related to pharmacy.
Absolutely. Thanks so much, Cheryl, and great to be with all of you today. I did want to share a little bit about what we're seeing from a healthcare trending standpoint, what we're seeing sort of overall, and probably you all have seen in your own data if you've taken a look at it recently. Obviously, healthcare costs continue to trend up year over year, and we are doing, as you can see on the slide, a lot to try to mitigate those trends, to really reduce the trends that we're seeing across medical and pharmacy costs year over year. But as we look at the medical inflation that we're expecting here in 2024, we see almost a 9% expected 2024 inflation. So that is a huge percentage that we're really trying to combat. For pharmacy specifically, it's now 27% of our total healthcare spend. So it is really contributing to what we're seeing in that overall inflation number. This is really driven by the new and expensive therapies that are coming on the market every day. And I know you all have heard a million things about GLP-1s over the last year or so. They have been all over the news in the last couple of years. So we've seen articles like you'll see on this next slide, lots of articles that have popped up on GLP-1s, how these drugs are working, what they're doing, how they can help your members be healthier, et cetera. So it's really prominent in everybody's mind how GLP-1s are impacting our overall healthcare cost trends. So with that, let's go ahead and dive into our panel discussion. But before we jump in, Rhonita, I would love for you to help level set for our audience today. What is the difference between medical and pharmacy benefits? In other words, how are medications handled through your medical and pharmacy benefit if they, and how does that impact our claims?
Yeah, no, that's a really great question, Megan. Most folks think of medical benefits strictly in terms of preventative care services like annual checkups or routine labs, or even emergency services like urgent care and ER visits. But similar to pharmacy benefits, medical benefits can also cover certain types of medications. Now, while coverage can sort of vary from plan to plan, the general distinction between medications covered on the medical benefit versus the pharmacy benefit is usually route and or method of administration. So what I mean by that is medications that require provider support or special equipment to administer, like infused therapies via infusion services, those are usually covered on the medical benefit. Now, on the pharmacy benefit, those drugs are usually able to be self-administered by patients. So things like simple injections or things that can be taken orally on a regular basis usually default to our pharmacy benefits. Medical drugs are usually billed by providers via our medical drug claim system, which is sort of a separate system that's housed to take care of those medical type claims that hit a medical benefit, while our pharmacies usually process and submit claims via our pharmacy drug claim system. Now,
Got
I
it.
will say, in order to function optimally, since we're talking about both medical and pharmacy benefits, um, it's usually best to sort of have a well-coordinated pharmacy and medical benefit strategy, because that'll lend itself to sort of allowing us to maximize affordability strategies across benefit. But it looks like we're going to get into hearing more about the challenges that we might face, or things that present themselves as struggles when benefits are managed separately.
Yeah, perfect. Thank you, Renee. That's great backdrop and a perfect tee up to our next conversation. Yeah, Joe, I know you've been doing a lot of work in the integration of the medical and pharmacy space. Can you tell us a little bit more about that?
Yeah, so we've seen some really good results in a study that we performed, looking at groups that carved in and carved out pharmacy benefits to see what those benefits might actually be on the medical benefit, not looking at the drug costs. And I know Brenden will get that into a moment, but Rhonita's hitting on something that's really important. There is this seam or this potential gap that can be created for medical and pharmacy benefits. So that gap of what's covered over on pharmacy when it's going through that system versus what the provider's infusing can cause a lot of inefficiencies, confusion, lack of access, and increased costs if it's not managed appropriately. And so that seam is what we focused on quite a bit when we were looking at that study. And I'm super excited to have Rhonita here because Rhonita has programs and can demonstrate some of the more tangible aspects of what that seam can create if there's not appropriate coordination. So Rhonita, do you have a few stories or some comments on the issues that can arise from having those two things separated or not coordinated well?
And I can actually speak to some of the things that we're doing here at Blue Cross. So we try and maximize our utilization management sort of cross-benefit strategies. Well, what does that actually mean? That means that we work hard to make sure that where there are pharmacy benefit alternatives to, say, certain provider administered drugs, whether it be the same ingredient or a different ingredient altogether that may be equally effective at treating a like condition, we steer toward those options before escalating to more expensive provider administered therapies. Oftentimes, provider administered therapies, I'm sure it's no secret to you all, come with the added cost of administrative fees. So in situations where medical and pharmacy benefits are managed separately, there may be situations where members and providers sort of get caught in the crack of that benefit gap that Joey spoke of earlier. This can lead to members not being able to access timely care. And then on the flip side of that, where you have benefit segmentation, that can lead to situations where members actually end up receiving duplicative therapy, which is obviously a safety and cost concern. Both of these situations can drive up the cost of our medical expense, and also present itself in the form of care delays that may result in increased use of emergency and acute services because of member either having duplicate therapy that results in sort of unnecessary side effects, or requiring certain emergency services because they weren't able to get their maintenance therapy started in time. So one example that I can think of specifically in our area is that we have a certain infused migraine medication called Vyepti. Our UN policy currently requires that certain pharmacy benefit agents be tried prior to access being granted to the provider administered Vyepti medication. Well, in situations where a member has a pharmacy benefit that's managed outside of Blue Cross, there may be a gap in the existing coverage on their pharmacy benefits that allows them to try those alternatives that we require before we will allow access to our Vyepti. So that's a tangible example of where if you have situations where your pharmacy and medical benefits are sort of managed separately and there's not a certain amount of coordination, it can cause sort of care delays and issues with members accessing timely care.
Excellent. Thank you for those examples, Rhonita. That really helps us understand the situation, kind of brings it home for us and the separation of those two benefits. So Joey, I've heard you talk about the power of one. Can you tell us a little bit more about what that is and what that means to us?
Yeah, and the power of one is really trying to solution for that gap, and it's demonstrating the value of having coordinated benefits. And when we did the study, which again, Brenden will show some of the great statistics on that work, it's taking a look at how a coordinated benefit has what's almost an untangible, until we've studied it, an untangible benefit to our members. Because what you can do on pharmacies, you can take a look at some of the charges we have, which is great customer service. We can do that and take a look at it through surveys. Lowering cost and increasing access. We can do that when we look at the cost of the medications. But when it comes to excellent clinical care, which the things that drive down hospital visits and emergency department visits, that's harder to track unless you have comparators, and that's what our study was looking at. I have one more example. I'm actually hoping Brenden will share of how his teams have worked through that gap, that seam, in which we use both medical and pharmacy data to drive to a really low cost option that, frankly, if it was separated, it wouldn't have occurred. And I think you'll see that when Brenden presents his solution.
Awesome. Thanks, Joey, for that setup. So here we're going to show a cross-sectional collaboration that we actually see in the work that my team gets to do. So top right-hand corner, we see medical policy. So again, talked a lot about that today. We have a medical policy for this product Olumiant. Patient was submitted for authorization for this medication, and they were denied. They didn't meet the criteria. Well, as is appropriate, sometimes there's unique circumstances. The provider went ahead, did a peer-to-peer with one of our physicians, and was able to get that medication approved. Being that it was a new start for the patient, they start low on that medication, kind of increase it or titrate that dose up to the appropriate dose. In doing so, they got at the stable dose for the patient, but these were still in those titrating. So taking multiple tablets of this medication to get the dose that was needed. So this was identified through our high-touch pharmacist. The high-touch pharmacist really is, that's a lot of what they're looking for, those outliers on things. And so they identified this opportunity for dose optimization. So they saw this and they reached out to the provider and they tried to say, hey, this patient should really just be on one tablet with each one of these doses rather than multiple. It's just a cost savings opportunity, but is not going to change the outcome for the patient. So they reached out, they were unsuccessful in getting that. So they reached out to us. Again, we're working with our Blue Premier partners on a monthly basis, having regular conversations about cost of care, quality, and those type of things. And they reached out to us and said, hey, can you help out with this one? So we did. We worked with our Blue Premier partners and reached out and said, hey, here's a situation. They were able to work with the provider, get the medication changed. This improved the pill burden for the patient. They're taking less medications each time they have to take something. Also resulted in $60,000 in savings. So it's a really kind of nice way to put together this collaboration that we see with medical benefit and with some of the things that my team is able to do. And then on the next slide, we're going to talk about really the relationship and kind of the work process that this looks at. So what is it? Our medical and pharmacy teams are continually innovating to reduce costs while improving the effectiveness and experience of the care and medications your employees receive. We do this through our deep relationships forged over 5 years of working with these partners and our deep understanding of the data and the history of providing actionable information to our partners on those opportunities. So our team of clinical pharmacists analyze both medical and pharmacy claims, identify treatment opportunities, care gaps, or medication gaps, and then work directly with providers in our Blue Premier relationships to improve outcomes and cost of care for our mutual patients. An example of this, so that's kind of word salad, right? So a direct example of this is high cost chronic disease state, diabetes, heart failure, asthma. They update guidelines periodically. And if patients are on those appropriate guidelines, it yields better outcomes for the patients. So my team builds dashboards to share specific members not on those current recommended medications, share those with their partners. It highlights the associated inpatient, outpatient, and emergency department spend to indicate that there could be a potential exacerbation of the disease and show that those members are not on the right medications and how this can cause higher unexpected costs. So these types of results, integrating data, leveraging our relationships, really caused us as an organization to do an independent study to look at the results of utilization of inpatient hospital care and emergency room visits. So this is the study that Joey has alluded to over the last couple slides. And so when we look at this, we worked on this self-funded group that carved out a pharmacy and how they compare. So ASO or administrative service only employer groups with integrated pharmacy benefit and lower medical spend on average by about $29.50 per member per month, or $354 per member per year for an average overall medical savings of 10%. What drives that 10% medical cost was 16% lower inpatient utilization and 8% lower hospital visits in the integrated population. So speaking of this, these results align with the work that we talked about my team doing, where we integrate pharmacy, medical data, and opportunities for better outcomes in our members. And then we're going to also look at, on the next slide, how this kind of compares with other things. So other competitors are doing this as well. So competitors, both national and regional, have conducted independent studies on the value of integrated benefits, leading to reduced medical cost and improved member outcomes. These integrated benefits have delivered excuse me, significant value for self-funded groups, members, and health plans. National and regional competitors have been conducting their own studies to quantify the value through the following 3 areas: reduced medical spend, improved clinical outcomes, and increased member engagement in care programs. So in this graph, you can see how Blue Cross North Carolina's integrated benefit compares to our national competitors like Optum, Cigna, and Aetna, and our outcomes tend to be superior to the outcomes that we see even with those providers with integrated benefits.
Excellent. Thank you so much, Brenden. That was a really interesting overview of that study that we did, and really looking forward to hearing some questions on that later on in the panel discussion. But before we get to that, I did want to talk a little bit more about specialty drugs with Rhonita. So Rhonita, as we heard, specialty drugs are a significant driver of the pharmacy costs, and we're seeing lots of new ones coming onto the market. What are we doing to solve for this?
That's a great question. especially when you take into account claims volume, right? So on average, specialty accounts for less than 1% of all of our claims, but it accounts for up to about 65% in my experience of all drug spend. We do a lot of things to combat that, but I want to focus right now on cell and gene therapy. So, we've made a tremendous amount of progress in the drug therapy space. And it's really exciting to see more potentially like curative treatments into the market to support, traditional chronic disease management options that have been around for years, right? But as I'm sure you all have come to realize, just as I have, along with advancement in drug therapies comes the question of, well, how do we support access and affordability of these products? Well, cell and gene therapies are among some of the most expensive treatment options available to our members, with the highest coming in at around about $4.2 million for a single one-time treatment. That can obviously be sticker shock, but when it comes to sort of life-changing and life-altering therapies, it's incumbent upon us to make sure that we do our due diligence to make sure we do all that we can to extend access to our members while also protecting affordability. So because of the relative newness of these therapies, there's still so much to learn about like the long-term impacts, including long-term efficacy, and other patient-related outcomes like unintended consequences that we likely have to solve for. But the question then becomes, so how do we balance providing access to these cutting-edge and potentially life-saving treatments while also maintaining affordability for our members and our groups? So here at Blue Cross, we work to ensure that we obviously have timely and quality utilization management programs in place as soon as these therapies hit the market. But with the high cost of cell and gene therapies, we also have to do our due diligence to make sure that we look to the market for innovative solutions and other beneficial programs that are available to us to help connect our members to the best care while also implementing sort of cost containment strategies. So that leads me into a program that I'd like to talk to you guys about called the Synergy Medication Collective. So the Synergy Medication Collective offers cell and gene therapy specific products that help us in providing risk protection to our stop-loss business to help shield them from high costs associated with these therapies once they're approved and make it through our UM process. Additional offerings that exist through the Synergy Medication Collective are available with the aim in supporting patient navigation services, which are designed to sort of help connect patients to authorized treatment centers, while also helping to sort of standardize reimbursement for these high-cost therapies. There's also an outcomes protection arm, which helps to recover ingredient costs in the event that these therapies fail to meet their intended outcomes in helping our patients. So there's a lot more work to do. There's a lot more that we have to continue to monitor, but those are just some of the tools that we have that we partner on with the Synergy Medication Collective to help protect our members and our groups from the high costs associated with these cell and gene therapies. Another program that I'd like to highlight as we move into our next slide is our free market health program. So our free market health program is a cloud-based platform tailored specifically to Blue Cross North Carolina business that supports a referral routing and market bidding system with use of our specialty pharmacy network that we maintain here at Blue Cross North Carolina. Free Market Health's market-based system directs our members to high-quality pharmacies within our network that provide specialty drugs at the lowest cost possible. So this is an improvement over traditional methods of pharmacy reimbursement that are largely made up of sort of static fees and static reimbursement fee schedules, actually. This program was born out of the innovative partnership, rather, with our free market health partners and the specialty programs and strategic ops team led by my brilliant senior manager that I have to give a shout out to, Rachel Littles. So we're actually just coming off of the high of celebrating our 1-year mark with this very innovative program. And we are encouraged by the outstanding program performance this far. In the second quarter alone, we saw an average of $200 to $7 in ingredient cost savings per claim, through the performance of this platform in our top trending drug categories, and that includes oncology and autoimmune diseases. This outstanding performance, actually coupled with the program adaptability, has led us to work toward expanding this program to additional lines of business beginning as early as mid-year 2025. So we're really looking forward to that, and we're really excited that we have another sort of tool in our bag to help us in our journey to contain cost associated with these specialty medications. The last program, if we can move into our next slide, is our High Touch RX program. So Brenden and both Joey mentioned this earlier, but I want to sort of give you guys a bit more information on this. So our High Touch RX program is one that is offered through our PBM partner that combines the power of medical and pharmacy claims data analysis, clinical rules, and clinical pharmacist expertise to identify and act on therapy optimization opportunities, usually resulting in cost savings to both our plan and our members. Some examples of these opportunities include duplicate therapy cases, dose optimization cases, meaning we may have members who are taking 3 100 milligram tablets where a single 300 milligram form might be available, and then generic transition opportunities. One generic transition opportunity that's top of mind for me is we recently had a launch of a generic form of Forteo, which is a medication used to treat osteoporosis launch. And working through our High Touch Pharmacist program, we were able to successfully convert about 27 members, resulting in about an $800,000 annual savings by getting those members to switch over to those generic options that are available. So those are just examples of some programs that we are leaning into and continuously improving to make sure that we do our due diligence to you all and our members in helping contain costs and provide expanded access to our members for our specialty medications.
Excellent. Thank you, Rhonita. Definitely need to keep a sharp eye on those specialty drugs. They are very expensive, as you shared, and lots of great programs that we're doing to try to help mitigate that spend. But again, as you said, make sure our members have access to these life-saving treatments. So thank you. That was a great overview of what we're seeing in specialty. With that, let's take another look at the GLP-1s. I mentioned at the beginning that we're seeing headline after headline about GLP-1s, and as you all may know, they're used to treat a handful of different conditions. So Joey, let's pass it over to you to talk a little bit more about GLP-1s and what strategies we might have in place to help manage the GLP-1 trends we're seeing.
Absolutely, and thanks Rhonita and Brenden for your information. And Free Market Health is probably the most innovative program I've seen in managed care in my time. I think it's absolutely brilliant. And I love the High Touch Pharmacist. It's next gen utilization management, and it's always in the benefit of the member, and it's helping our employer groups save money. But yeah, GLP-1s. If we can move to the slide, I want to show you guys what our populations look like. So this is a little bit of an eye chart, but bear with me. This is the population that we have in our self-funded, around a total of 370,000 members, and possible GLP-1 use is what I call this. And it's actually members that aren't currently taking a GLP-1. These are ones that are eligible but not yet on one. And so if we go around this fancy Venn diagram, you can see that the large cohort of diabetes there, 17.5 thousand individuals in that kind of darker blue shade there. And those are individuals that would be eligible for medication, GLP-1s for diabetes. Think about things like Ozempic is often in the news. Trulicity is an example. These are specifically used for diabetes, and we only allow them to be used in diabetes because that's what the FDA has approved them for. Additionally, we see other cohorts here, hypertension and cholesterol issues, dyslipidemia there. Those folks range in that 70,000 range, and this often overlaps with diabetes. And the same with established cardiovascular disease up in right-hand corner. These are folks that have already had a heart attack, already had a stroke, or other cardiovascular issues. Lastly, we'll look at that BMI plus 27. Those are folks that have a excessive body weight. So their BMI is higher. These are our weight loss drug population. So these are the folks that you might see on could be eligible for Wegovy, could be eligible for Zepbound, lesser so Saxenda is also there, but there's also some oral medications out there, non-GLP-1s, that don't pull as much weight loss, but are a little more cost effective. They're lower in cost, that's for sure. And the reason these all overlap and the reason I want to talk about them a little bit is because it'll tee up into some of our outcomes discussions we'll talk about in a second. There's a pocket right in the center, and it's where established cardiovascular, excuse me, it's not in the center. I lied, folks. It's a little off to the center. It's that 3,998, that 1.1% of individuals that have an overlap of the weight loss component and the cardiovascular disease they've already established had a heart attack or stroke. Those are the only folks right now that we have seen health outcomes for. And I don't mean extended weight loss. I mean, we've shown, clinical data has shown that heart attack, stroke, and even death can be prevented in this small population. But it's very small when we look at this bigger diagram here. So I'm going to focus in a little bit on weight loss drugs because that's what most people are talking about. And we can go to our next slide and talk about what the data is showing, because I feel like people need to be informed about the conundrum that is GLP-1 and weight loss. The whole industry is dealing with this conundrum. And so as we look across the data, there's both goods and bads. Good. These weight loss drugs work. You do see a weight loss of 15 to 20%. Some in the pipeline are coming above 20% and almost reaching towards that bariatric surgery level. That is something we haven't seen before. Historically, we've seen oral weight loss drugs maybe hit 10%. So this is a good drug for weight. These are good drugs for weight loss. The long-term outcomes are really only in that small 1.1% of the population I showed you before. People that have had heart attack, stroke, and unfortunately even death, those folks fit a population where we've seen being on a weight loss med, specifically Wegovy, they can prevent a heart attack, stroke, or death. But it takes a lot. It takes 66 individuals with perfect adherence for 3 years to prevent one heart attack, stroke, or death. So it does cost a lot of medication to get to that one prevention. We'll go over that in the next slide, but we'll stay here for a second. Real world data. Thumbs down on this one, guys. What we're seeing in real world data, claims data, is that around 70% of individuals that start on a weight loss drug will not continue after the first year. 70% will not continue after the first year. And I just told you to get that heart attack, stroke, or death prevention, you got to be on perfect adherence for 3 years. So we have a problem right there. And I want that to be highlighted because I'm going to get back to this in a few slides. People are not staying on the medications. And then lastly, that sticker price you're all talking about, this is the sticker price. This is not a discount price of around $12,000 to $18,000 per person per year that are on these medications. Those are question marks. The reason they're question marks is because medications can cost a lot, but if we get the value out of it, that's okay, right? That's what we want medications to do. And I'm going to put you through a quick thought exercise. And I hope there aren't too many pharma folks on the line here. If they are, because they're gonna yell at me about this thought exercise. We're looking for trying to evaluate the cost of that long-term prevention, the prevention of heart attack, stroke, and death when associated with weight loss. So I just told you 66 people have to be perfectly adherent for 3 years. Take an average price of $13,500 per year on those members, and we'll give a generous haircut on what the actual cost. Say we put a 30 to 50% rebate on that drug. That comes to $1.3 to $1.8 million to prevent a heart attack or a stroke. The cost of a heart attack or a stroke is somewhere between $17,000 and $33,000. Now, I'm not saying don't do this because I'm not putting a value on someone having a heart attack and a stroke. Those are horrible things. What I'm trying to pose here is the conundrum. The conundrum of the cost of these medications for those outcomes versus what's currently going on. And also, these aren't the only medications that can be used to prevent heart attack, stroke, and death. You have one in your medicine cabinet. Aspirin does it. Cholesterol meds do it. There's quite a few other medications out there. There's other things going on in the market and in medicine that can prevent heart attack, stroke, and death. So it poses the question to everyone, they're good drugs. They do what they're supposed to be doing. And you talk to a lot of people that are on them that have lost that weight, it can be life-changing. But the value assessment of it is very, very difficult. So where are we going with the solution to this? And we can jump into our next slide, and I'll explain that. Oh, let me scare you a little bit first. I'll scare you a little bit by saying these are the costs if you take some of those bubbles and kind of that I talked about and extrapolate them out. If everybody was on a weight loss GLP-1 that was eligible for them, and I think it was a pretty large percentage back on the previous slide, and double-digit percentage, we're looking at almost $200 PMPM, which is more than a pharmacy PMPM in total. Well, what we know is that many people are not on weight loss medications, but they're eligible for them. Currently, we're seeing about 3%, 2 to 3% of individuals that could be taking one of these medications would be on them. So it's fairly low. If you take a look at what that costs with UM and with some more realistic parameters, it's somewhere between that $12 and $18. And should you choose not to go with a UM policy, which is an option out there, I don't recommend it. You can see that inflate to 13 to 22% PMPM. So as you're thinking about the cost of these medications, they are fairly expensive, and there's a lot of people that are eligible for them. 30% of North Carolinians are obese. So that would be a large percentage of North Carolinians that could be taking a weight loss medication. We're only seeing somewhere between 2 and 3% right now. So now let me get you some solutioning. So the next slide, I talked to you about 70% of individuals stop taking the medication in the first year. That same study actually looked at different cohorts, different groups of individuals that were performing better. Folks that were performing better and staying on the medications were associated with an endocrinologist, a weight loss specialist, or some sort of specialized program to keep them on the medications and to manage other items like lifestyle, self-monitoring, your nutrition support. And so that's where we've keyed in on a solution here called Vita that we're bringing 1/1 of 25. This is a program in which we can narrow down who is managing these individuals that are getting prescribed weight loss medications, not just GLP-1s, but the oral ones, or even just coaching for better lifestyle management. So what the program does is I'm going to say lock in. It only allows weight loss medications to be prescribed by a Vita provider because they're taking on the responsibility of focusing on a holistic side of this patient, not just prescribing the medication saying, I hope we lose weight. They're looking at those self-monitoring components. What are those emotional triggers that lead us to not moving, not exercising, or not eating right? Or are there certain foods that are triggers? It's looking at medication adherence, like we just talked about. You're more likely to stay and get those outcomes if you're adherent to the medication. But furthermore, you can see there's a projected decline in GLP-1 utilization. That is bending the curve. I'm not going to say it's going to drop the trend to a different direction, but it's bending the curve in several ways. One, it's assessing, does someone actually need a heavy hitter like a GLP-1 to get a 15 to 20% weight loss? If they're at a BMI of 28, maybe 10% is good. And maybe that medication, the lower cost medications could be doing it. Or maybe just management outside of medication could be accomplishing that. So it's standardizing that approach towards helping our members do what they need to do outside of medication in conjunction with medication. Additionally, there is this idea out there that people could be tapered off GLP-1s. If you do the right things, there are certain people that could stop taking those medications rather than continuing on indefinitely, which is kind of the way a lot of the studies were set up initially, was just keep taking the meds. So this program is exploring who can come off these medications, bolstered by all those other tools that they've been given with their clinician helping to get them there. So pretty excited about this solution because it's answering literally the questions we're seeing that are coming out of the data when it comes to GLP-1 medications.
Excellent. Thank you, Joey. I know we are all excited about the new Vita program coming to market. Clients have been asking me over the last year or so about how can we better manage these GLP-1s and the trends that they're seeing. So really excited to have that program come into market as an option for our self-funded groups. So thank you again, Joey, for that overview of GLP-1s in general and the new Vita program. Before I turn it back to Cheryl to do some question and answer, I did want to give each of our panelists an opportunity to give a closing thought about, what do you see as the most critical for the future in managing costs in the pharmacy space? And Rhonita, let's start with you.
Yeah, so the thing that comes to mind for me are just staying on top of innovation and strategies. So as we see increases in complex or increases in sort of cell and gene therapies and therapies that are designed to treat ultra rare disease that come with a high cost, we have to stay on top of innovation in our strategies. So keeping the ear out there for like industry leading programs that address these needs, whether it be patient access or cost containment, that's sort of at the forefront of sort of what I'm focusing on and looking to the future, while expanding and building on some of the existing things that we have in our toolbox, like our free market health program, and expanding that to sort of help us manage and contain costs. So, I worry about that less than 1% of claims impacting our over 60% of drug spend. So that's sort of my focus going into the future, if that makes sense.
Makes perfect sense. Thank you, Rhonita. Brenden, let's go to you next.
Yeah, I think it's probably just because of the work that I do, but I really believe that one of the most important thing we can do is continue to tap into the resources already available and accessible for our members. Those are our pharmacists, right? Our pharmacists in the community, our pharmacists in provider offices, wherever they are, they're providing a great service, and they're really doing a lot when this whole conversation is about medication management and cost management of medication. Who better to engage with the cost and utilization of medication than the pharmacists that tend to be underutilized out there. And that's why I'm excited that our team gets to work directly with them.
Excellent. Thank you, Brenden. And Joey, why don't you finish us up here?
Yeah, I think it's partnerships and optionality. And let me explain that. Partnerships in that there is a whole landscape for which medication touches, and it's often thought about in a pretty siloed fashion. It's often just thought about, you get the drug, right? But those drugs, I've actually heard that we spend more in the United States on drug problems than we do on the drugs themselves. So how do we solution for that? And it's by partnerships with either providers, like Brendan's talking about, innovative solutions like Rhonita's been talking about, or partnerships in and of ourselves within the clinical community between pharmacists, physicians to better care. And when it comes to optionality, we're in a state of unknowns as we evolve faster and faster in healthcare, which is wonderful. Gene therapies are curing conditions. GLP-1s are doing things that we did not think were possible. But in the uncertain periods, we need those options because we can't mandate what people should be doing. In those uncertain periods, that's why we create the options. We create the Vita. We create we bring that partnership in. I shouldn't say we create it. We bring that partnership in for our groups to be able to elect that. And so as we think from the full spectrum for which pharmacy and medications are being used, we need to have strong partnerships with the single goal of making healthcare more affordable for our members, bettering access so that they can have that affordability, and then the clinical outcomes for it. So all of that has to come together. And that's why I'm so excited to have and love having Rhonita on the team and her specialty work, Brenden working with our providers and with those more integrated type approaches because it brings the whole package together.
Perfect. Well, thank you all to each of our panelists for all of your overviews today and the information that you provided. Cheryl, I'll go ahead and turn it over to you for some questions that have come through in the chat.
Yeah, absolutely. Thank you for that, Meaghan. I do want to clarify for something because we talked a lot about that exciting study and the results that came out, but we said things like our study, the study results. I wanted to clarify if this was our study that we did, or if I could clarify for the audience, if this was our study that we did, or if we worked with a third party to get these results.
Yeah, that's a good question, because we did want this to have some integrity to it, and I know there's always the optics of blue zone analytics teams coming up and conjuring up the outcomes. So no, we invited a third party consulting firm to come in, take a look at all of our data, and had third party actuaries take a look at the outcomes from it, and make sure that they're actually matching things up fairly as well. Because as we've had discussions before with other groups, like it's not fair to compare a very lean benefit with a very rich benefit. Like if you have a carve out that has a very lean benefit and a carve in that has a very rich benefit, they're going to have differences. And so that consultant came in with dozens of points of testing to make sure that we were comparing apples to apples, and that we weren't kind of cheating the game here. So it was very important for us to get that third party in to get their assessment, so that we could feel confident that we were telling the truth in our story.
Absolutely. And those were, I mean, not to our own horn, but those were great results that we saw. And it was great to be able to back up these claims and have something that we can point to really showcase the value that can be brought. So thank you for reviewing that for us.
Sorry, Cheryl, I'm so excited. I keep stepping on you there. Just one point to highlight, that was a 10% reduction in medical costs. And one thing to think about is, where does that show up when you're evaluating a pharmacy program? Because oftentimes when we evaluate pharmacy programs, we're looking at rebate discounts, network discounts, other clinical programs. But a 10% reduction of medical costs can be something like $60 PMPM. So $60 PMPM is a massive discount if you apply that to like the ingredient cost of drugs. I think that would probably come somewhere in like 30% of what you would see on a pharmacy PMPM. So just to get back to the fundamental, just to get back to break even, there has to be a very, very good pharmacy contract out there to carve out that pharmacy just to make up the difference you're going to see on the medical side.
Well, thank you for that. I do have a question from registration that I think would probably be best for Rhonita, or maybe Rhonita and Joey, y'all can tag team. Wondering what programs and solutions Blue Cross plans to launch in 2025 to help manage brand specialty pharmacy costs, things of that nature. Just sort of looking ahead on the horizon.
Yeah, no, that's a great question. Obviously, I think top of mind is continuing to maintain and improve upon some of the programs that exist, but where their opportunity presents itself, it's also incumbent upon us to sort of expand our existing programs to additional lines of business. So one of the things that we look forward to, as I mentioned earlier, is expanding our free market health, which again is our market-based system that supports bidding and live marketplace bidding for our specialty medications on our pharmacy benefit. And we're looking forward to expanding that offering to additional lines of business around mid-2025. So that's one of the things that I can think of that we're doing to sort of help contain costs going into 2025 for a broader audience.
Yeah, and as I mentioned before, I think that's the most innovative program I've seen in my time in managed care. It's also solving problems that we are seeing pop up in the industry around specialty medication and discounts, right, Rhonita? Where it's like, if you go to a single pharmacy to get all of your specialty medications, you might get a really, really good overall discount. But there are kind of winners and losers almost in that discount, where some drugs are kind of discounted and other drugs are really discounted. In this program, you're going after each product in that moment in time to get that discount. And so when it comes to things we see around maybe even lawsuits out in the market, where folks are seeing, why is this, I'm locked into this pharmacy and I'm not getting a very good discount. Well, this solution is outperforming from what we see, kind of that single lock-in type approach. It also gives optionality to members for where they want to go when it comes to that whole network, with those discounts applied in real time. So super cool, super excited to have that on our ASO book.
Lots of exciting things coming down the horizon. All right, Brenden, wanting to put you in the hot seat now, if I could. I was wondering if you could elaborate on any of the work that your team does to help close gaps in care for diabetic members at all.
Yeah, great question. And some of the things that we focused on is our Blue Premier work. And so in those relationships we have with our Blue Premier partners, we specifically have programs where we identify members who are not controlled. So they begin the year with an A1C above 8, so they're not controlling their diabetic appropriately. We highlight those and we share those with our Blue Premier partners as its own report as far as potential open gaps. And we track that through the year with a target of at least 35% of those gaps being closed for the patients. What's also nice is we've talked a lot about diabetes, hypertension, and kind of like the things going hand in hand. We also highlight if they have a hypertensive gap. So along with that, if the patient has a diabetes gap and a hypertensive gap, so their blood pressure is not controlled, their blood pressure is showing over 140, over 90, then the pharmacist can work with them, or the provider can work with them to help improve that. I spent a lot of time on the Blue Premier, but I do want to also call out, another thing that my team has is we have our More Than a Script program where we're working with community pharmacies, mostly in the fully insured business. So again, we're looking at what the expansion might look like in future state, but with our fully insured commercial business. So the More Than a Script program is doing the same thing. So working with community pharmacies, engaging them, having very structured visits where they can communicate with patients on improving their outcomes. And so again, two major things that my team's really working on, Blue Premier through the reports as well as the More Than a Script program for improving those outcomes.
Wow, amazing work. Thank you for sharing with that.
Yeah.
All right, so moving into a couple of additional questions. Wondering how we can support our employees with the high cost and shortages of weight loss meds, but also ADHD medications.
Yeah, I can take that one. That's been a challenge. Drug shortages has been really a big challenge the past 2 years. And those are the two ones I think about. There are a few others, but first we've had to at Blue really create a policy, procedure, and kind of action initiative around medications that go on shortage. And I want to explain kind of some of the things that we do when we evaluate it. First, every month we take a look at what drugs are going on shortage, are there new ones on shortage, and what is the impact? Because some medications go on shortage that really don't have an impact on the pharmacy benefit, but definitely ADHD and GLP-1s are there. So when we see that kind of impact for our membership, the first things we start to do is how do we increase access when it's not there? And so some of those things I can speak to ADHD. First thing we did was add more generics that we would not normally cover because they're a little bit higher cost, but they're lower cost than say than not having any access, where you're going to have problems going to the doctor more often. So we increase the formularies breadth. Sometimes we'll also, in the sake of ADHD, add the brand name medications back on, so that if a provider cannot switch to an alternative that's a generic, they can have access to the brand name medication at that time. We also allow our clinical pharmacists that review all the exceptions that come in through prior authorization. If they have a provider that's saying, I can't get the drug I want, this is the one because of shortage, and this is the one I want, we grant short, about 3-month window approvals for that. Additionally, we pull back on some of the utilization management restrictions, maintaining safety. But when it comes to something like quantity limits, what we've seen with our members is with ADHD, they might be trying to get to a 20 milligram dose with 2 10s, but the quantity says you only take 1 a day. So there's a limit. So when we remove those limitations, they have access to that medication. We're also working on making sure that members aren't restricted or locked into a maintenance type scenario. Say they have to go to mail order, group elects that. Well, with GLP-1s, the mail order might not have that, but the local pharmacy does. And so we need to make sure that that is not something that's bogging them down. So we remove them from those lists that require 90-day fills, which might not be available. So the plan's doing a lot. And we are open to feedback from groups. If they're having acute issues, we can look at what your options are that you might not be aware of, alternatives on the formulary. Maybe I've even reached out to our pharma partners at times and said, do you know where you guys have access to certain medications? And we can try to support that way. They don't always know, but sometimes we can get that way. So we've developed an entire process of how to get out of the way and encourage appropriate utilization of what is available for our members when it comes to drug shortages. Unfortunately, a lot of that has very little to do with the health plan, and the whole industry is dealing with it, but we're trying to take our part in pulling back where we don't need to be and supporting where we do need to be.
Thank you for that. Very eloquent explanation for kind of a little nitty gritty of a question. So great job on that. We do have a question that popped up about the eligibility for the GLP-1 management with Vita that Joey mentioned earlier. Being just sort of aware of what time is, the Vita program actually consists of a couple of different solutions, including the GLP-1 weight management that Joey mentioned. And it sort of varies based off of your funding arrangement and size as well. We recently, I want to say in August, but I could be wrong on that, did a more in-depth solution spotlight on that solution as well, and it covered all three. So I'm actually going to link the YouTube recording to that in the chat for everybody to be able to access, and you can view that at your own time, whatever you want. And if you, of course, have any questions, you can reach out to your authorized Blue Cross representative, and they can be happy to answer anything you that may pop up. So that is actually all the time that we have for today, unfortunately. I do want to provide a friendly reminder to keep a lookout for the post-webinar survey for a chance to win that Amazon gift card. In the link, I'm also going to provide a chat to the U+ Blue landing page, because believe it or not, there's actually a lot more information surrounding our work with pharmacy landscape that we weren't able to get to today. You can find a few more details by navigating to that link that I just posted there in the chat. This webinar is actually going to be our last solution spotlight of the year. We have a lot of exciting things coming in 2025. Of course, your feedback on the survey will help influence that, but be sure to keep a lookout for some more things to come next year. Meaghan, Joey, Brenden, and Rhonita, it was a pleasure having you today. I hope everyone has a great rest of the day, and we look forward to seeing you in the new year. Thanks all.
Thank you.
Thank you.
Thanks all.